everyone. This is my final lecture for your multi-system disorder class, Nursing 2244. This one is going to focus on alterations in cognition and sensation. Some of this will be a review from the third semester, and then some of it will be an extension of what we learned in our third semester lectures. This particular one is going to focus on things like intracranial pressure, in particular increased intracranial pressure, and how to intervene as a nurse, how to recognize when a patient is suffering from increased intracranial pressure. We'll also spend some time, just a little bit of time, talking about basilar skull fractures, some different head traumas, as well as meningitis, some encephalitis, and then we'll also do like a quick little review of spinal cord injuries with some focus on spinal shock and neurogenic shock. So let's get started. So what is intracranial pressure? It is simply the pressure exerted in the cranium by its contents. Now the brain, or I should say the contents of your skull or the cranium and the intracranial space is comprised of the brain, blood, and the cerebral spinal fluids, those three components. And this will be important as you kind of go through understanding that these three things are what reside in your cranial vault. And if there's damage or increase in one, you have to have some kind of compensatory mechanism to help relieve that pressure, because the skull itself does not have the ability to compensate for that in any way. So as we go through this, we'll kind of talk a little bit more about the brain, the blood, and the CSF as it relates to the intracranial pressures, and especially in the increased intracranial pressure kind of concept. I would encourage you to watch some of the videos that I have on the very last slide, or one of the very last slides, because they do a really nice job of explaining this process of intracranial pressure and regulation of that particular concept. So it is measured in your lateral ventricles, and the ventricles are just that part of the brain that they will actually place the monitor into to record the pressures for that. Normal pressure is usually 10 to 15 millimeters of mercury. Anything above that is considered increased intracranial pressure. The one thing we don't want to see is it go above 20, so anything above 20, especially for 5 minutes or more, is of great concern, because we know when the pressure gets that great that the brain itself is struggling to perfuse, and then we can start to see some irreparable damage done to the brain tissue. And then anything above 30 will create a loss of compliance. And any normal activities, so these are things that can just increase the pressure that we would do on a normal basis of life, things like coughing, sneezing, bending, performing the Valsalva maneuver. Any of those things can increase the intracranial pressure. So these are going to become important as we go through nursing interventions and start to, when we start teaching our patients and stuff like that, and things that we need to look for as nurses, these types of activities, because these are the things we don't want to see happen in our patients who have had some kind of brain trauma that has caused them to have increased intracranial pressures. So some quick distinctions of what can cause increased intracranial pressure are things like brain swelling, which is this increased bulk from increased cerebral blood volume, as well as cerebral edema, where you have volumes of the brain tissue increase from abnormal fluid accumulations, causing that ICP. And there are three types of cerebral edema: vasogenic, cytotoxic, as well as interstitial, and we're going to look at those here in a minute on the next few slides. So the first type of cerebral edema that can cause increased intracranial pressure is the vasogenic edema, and this is caused by an abnormal permeability of the walls of the cerebral vessels, which allows the protein-rich plasma to infiltrate or leak into the extracellular space of the brain, and this allows it to pull in the white matter. This usually occurs in adults most often. That's where you're going to see this, and it can be caused from abscesses or tumors, hematomas, or like bruising type things into the brain, and inflammatory processes. The second type of cerebral edema is the cytotoxic, and this is from cerebral ischemia and hypoxia, causing the cells to swell even further. This causes cell dysfunction and irreversible cell death. And that makes sense because we know if the brain is deprived of oxygen, or any cell for that matter is deprived of oxygen, it will cause cellular death. And so this gets into a vicious cycle here with the ischemia and the edema occurring. It also occurs due to a change in the membrane integrity from the hypoxia, causing the sodium pump to fail. So the sodium goes into the cell, and with it, it pulls the water, because remember, sodium sucks. So wherever the sodium goes, the water is going to follow. And then when that happens, it increases the intracranial pressure. And when that transport from the ions occur, the brain is quickly depleted of available oxygen, glucose, and glycogen, and it converts to an anaerobic type of metabolism. And these may lead to vasogenic edema, which we talked about on the previous slide, which then worsens the condition. We oftentimes see this with like our coup contra coup injuries, where the head gets kind of pushed forward and back, so you get a kind of this bounce back effect, or a diffuse axonal injury where it's kind of like more like a shearing of brain tissue. And then also near drowning as well as destructive lesions can cause this type of cerebral edema. Okay, and then the final type of cerebral edema is the interstitial cerebral edema. And it's increased interstitial fluid between the cells in the brain from compromised drainage. This can be caused from hydrocephalus. It can also be associated with increased blood pressure or an increase in the CSF pressure. Maybe there's a problem with CSF draining. You know, your body makes CSF every day, and sometimes the system of regulation where it should be like recycling and getting rid of, sometimes one of those processes gets affected, and so you may not be able to drain the CSF the way you need to. So that can also lead to this interstitial cerebral edema. Performing the Valsalva maneuver, as well as having too much PEEP, if the patient is mechanically ventilated, can also be associated with this cerebral edema. So kind of when I talked a while back about Valsalva, you don't want anything that increases intra-abdominal or intrathoracic type pressures, because anything you do down lower can increase pressure upstairs. So this can also lead to more interstitial edema, as well as for patients on ventilators. It's going to be important to monitor your settings, because you don't want too much PEEP going on with your patients, because it can increase this interstitial cerebral edema. And if we're already fighting with increased pressures, we don't want to do anything that will further exacerbate that problem. So as it says, think about this. The ability of the brain tissue to accommodate change in a space is limited. Like I said, if we think of our skull, and we know that, you know, when we're first born, we have little fontanelles, we have our suture lines that are not closed in our skull, and those are all used to accommodate, number one, the birthing process. You know, so things can compress and come as it comes down the birth canal. But then even as we grow, you know, our brains start to grow, and so the suture lines they're not fused yet. We have room to accommodate for our changing brain. But after we become adults, that we lose that compensatory mechanism. The brain, the cranium itself, I should say, the skull, can no longer accommodate for what is going on inside. So the brain can expand without serious effect on the flow of the CSF, on the amount of the CSF, the cerebral circulation, all that stuff kind of plays into that. So you have to maintain this nice balance of those three components that we talked about that make up the inside of the cranium, which is the brain, the CSF, and the blood flow. So those three things have to stay in a nice state of equilibrium, or a state of homeostasis, in order to be in balance with each other. And so that's an important concept to understand when you are looking at regulating intracranial pressures and things like that. So just keep these things in mind as we go through this lecture when we talk about ICP, increased intracranial pressures, especially. You know, we'll spend a little time talking about the different types of leads, but I'm not as interested, do you know each one in, you know, particular detail, because they're all going to go back to regulating ICP and knowing how to intervene and what nursing actions you need to take for these types of patients. Okay, and no ICP lecture would be complete. I've watched a million of these on YouTube over the course of the years, and every one of them will talk about this Monroe-Kelly hypothesis or Monroe-Kelly doctrine. Sometimes they'll call it hypothesis, sometimes they'll call it doctrine, but it basically states that the volume in any of the if the volume of any component increases, the volume of the others must decrease to maintain normal pressure in the cavity. So when we're looking at ICP, for instance, if we have an injury to the brain that causes increased swelling of that brain, and that pressure starts to rise from that, one of those other things has to compensate for it. So either the CSF will slow down its production to decrease the amount of CSF that's inside the cranial vault, or blood flow will be slowed down to the brain. It's a mechanism for compensatory, but it's not necessarily one that's the best for preserving life. But that's just how it works. But that's how what this hypothesis is looking at, is just basically that if one thing increases, one of the other two has to decrease to try to regulate the pressures within that cavity. Okay, another important concept to understand when we're talking about intracranial pressures is something called a cerebral perfusion pressure, or CPP, and it's simply the amount of blood flow from the systemic circulation required to produce adequate oxygen and glucose for the brain metabolism in order to perfuse those cells. So it's the ability to actually give the brain the oxygen and glucose that it needs to do its job. So what are normal pressures and ICP measurements? So when we're looking at a cerebral perfusion pressure, this CPP, and you will see a little variation when you're looking at different references, but typically 60 to 80 is considered normal in that range. Some will say 60 to 100, and that is okay to go up to 100. Anything over that, you might start seeing too much pressure within the brain itself from that CPP. But the normal cerebral perfusion pressure you want to keep between about 60 to about 80. That's kind of your normal reference range for that. Like I say, don't panic or be like that's not right if you hear 60 to 100, because some references will use that, and that is, like I said, completely fine too. ICP measurements, what are those and where should they be? ICP usually, the book says it should be about 10 to 15 millimeters of mercury for a normal ICP. Again, you're going to see some variations. I've seen some that say 5 to 15. I've seen some that say 7 to 15. But your IGI book says 10 to 15, so we'll use that as our reference for us. But those are your normal measurements for those two components, the cerebral perfusion pressure as well as your ICP. Okay, and obviously I got ahead of myself, which is not uncommon for me to do. But here's looking at that again, and it says normal, and I've got 70 millimeters of mercury, or you may be seen as 60 to 80, which that 70 lies right in the middle. Like I said, you will hear some people go up to 100, and that is okay as well. Anything above 70, you haven't maintained an adequate blood flow to the brain. So if your CPP is like 60, 70 on up, that means you've got adequate oxygen, adequate glucose going to the brain. That is what we want to see. 50 and below, you can start seeing some irreversible neurologic damage done to the patient. Anything below 40 on a CPP means there's no flow. And typically when we start seeing things below 40, the outcome for the patient usually is not good. That is something we do not like to see, is a CPP below 40. And then anything over 100 is a hyperperfusion. And you can kind of see down in my reader, my little presenter note, it talks about hyperperfusion. Maybe these people may be at an increased risk for hypoxemic respiratory failure, or ARDS, which can contribute to their cerebral edema and prolonged mechanical ventilation. So you can kind of read the little notes down there if you want to about hyperperfusion. I'm not going to test you on it. I don't think it's something that's super important for you to know at this point, other than hyperperfusion because if you think about it, the brain is getting, there's a lot of perfusion, and the way you calculate a CPP is you're looking at the mean arterial pressure and the ICP. So if you have a very high blood pressure, that would raise your mean arterial pressure. It does put the patient at an increased risk for like intracranial hemorrhages, in particular subarachnoid type hemorrhage. But I don't want you to get focused in on that hyperperfusion as much as I want you to understand what a normal cerebral perfusion pressure should be. Like I said, 70 is great, 60 to 80, 60 to 100, anything in that range, I'm fine with you understanding. Just know that that is a normal, that's where we want them to be. Know that anything under 50, you start to see some irreversible neurological damage. So we want to try to always keep it above that. And more importantly, as well than that 50, is anything below 40 would indicate a poor outcome long term for this patient. Probably not going to recover from that. Your CPP, this is something I do want you to understand because it's important that you understand how do we calculate a cerebral perfusion pressure, and it's simply your MAP minus your ICP. So if the patient were to have an ICP monitor in, we are always checking mean arterial pressures. Preferably we have a central line to do that, not just relying on doing manual blood pressures and calculating the MAP ourselves. But if we do have to do that, I'm going to show you how to do that here on the next slide. But to get your CPP, or that cerebral perfusion pressure, it's simply your MAP minus your ICP. So I've given you an example here. If you had a MAP of 100 and an ICP of 15, then you get a cerebral perfusion pressure of 85, which that makes us happy because we're still in that range, whether, like I said, 60 to 100, 60 to 85, we're all happy with this particular reading. And again, that ICP is in a normal range as well. So this would make us feel good if we had a patient that we're monitoring intracranial pressures from a neurotrauma. This would be a good situation for us. So how do we get the MAP? And I'm going to show you that on the next slide. Okay, so now I'm going to tell you how to calculate, or tell you again, or reintroduce this. I know we've talked about this on how to calculate a MAP. Now I want to start off by saying, if you printed this PowerPoint off before this evening, which is Sunday, the 11th of April, I made a mistake on this, and I realized it as I was getting ready to start talking to you guys as I was reviewing this, that I actually put this backwards, and then I was like, what have I done? So I hope none of you printed. If you did print it off, I just want you to make sure that you get rid of this particular slide out of your PowerPoint and print the new one off. On the old one, I had this backwards. The way you calculate this is it is 2 times the diastolic pressure plus the systolic pressure divided by 3 equals your MAP. On the previous slide, I had put in the systolic pressure times 2 plus the diastolic. I had written it backwards. So understand, in order to calculate the mean arterial pressure, or this MAP, you take 2 times the diastolic plus the systolic and divide it by 3. So I've given you an example here. If your blood pressure was 84/40, you would take 40 times 2, which is, that's your systolic pressure, times 2, plus your 84. So if you follow the math over, that gives you a total of 164 divided by 3. So it gives us a mean arterial pressure of 54.67. Okay, now we're going to take that number and we're going to actually calculate our cerebral perfusion pressure, and we're going to do that by taking our MAP, which was at 54.67, and you can see here I've given you an intracranial pressure reading of 20, which I don't like that number because that's not a good number to begin with. It's high for an ICP. And so we're going to take that mean arterial pressure, which is at 54.67, minus the 20, which is our intracranial pressure reading, and we're going to wind up with a cerebral perfusion pressure, or CPP, of 34.67. So what is the expected outcome for this patient? If you think back to the slide we just talked about, I told you anything under 40, the outcome for this patient was poor. So the chance of this patient surviving is probably going to be pretty minimal. And if they do, they're probably going to have very, very significant neurological deficits from this particular injury. So what compensatory mechanisms come into play then to help us regulate intracranial pressure? The blood and the CSF are really the only components or compartments that can compensate for that increased intracranial pressure. And there are three mechanisms that help to maintain the cerebral flow or the blood flow to the brain, and that's compliance, autoregulation, and then its last-ditch effort, which is not a good one because this usually happens towards the very end and something we don't want to see, and that is herniation, but it's the last-ditch effort to try to decrease pressure within the cranium or that intracranial space. Okay, so looking at these compensatory mechanisms, compliance. This is when the brain adapts or it becomes tolerant without increasing ICP, and it maintains its O2. So the brain is able to regulate itself, or it adapts itself without increasing its pressure, and it maintains oxygenation. So those cells are still getting perfused the way we want them to. This works by displacing the CSF into the spinal canal or increasing absorption and decreasing production of that CSF. And I kind of talked about that earlier on one of those other slides, where that's one of those things the brain tries to do to accommodate itself, or one of these compensatory type mechanisms where it's trying to adapt. So one of the ways, because we looked at that Monroe-Kelly hypothesis, I know I have no room within the cranium. The brain has suffered an injury. It's got some swelling. What can it do to regulate or maintain that homeostasis that it needs in the cranial vault to keep the pressures from going too high inside the head, as well as maintain its oxygen and glucose metabolism? And so it can do that by displacing that CSF, by either putting more into the spinal canal or increasing the absorption or decreasing the production of that CSF. It can also lower the pressure of the venous system, and the cerebral arteries will start to constrict down. So it starts to restrict blood flow to the brain itself, because again, that will decrease the amount of volume that is within that cranial vault, and that's a part of the autoregulation compensatory mechanism process as well. So we'll talk about that here on the next slide. So looking at some of the autoregulation types of compensatory mechanisms is things like pressure regulation, or the ability to regulate the diameter of the vessel itself. And so think about this in terms of like systemic vascular resistance, where you have, the pressure that's exerted. So what happens is when the systemic blood pressure rises, the cerebral arteries will constrict themselves. So normally, when you have a rise in blood pressure, you see that everywhere. But what happens is the vessels themselves will constrict to protect from engorgement. So instead of allowing that extra blood flow to go to the brain, it will maintain a steady flow to try to regulate that pressure itself within the brain, if that makes sense. So that's just one of those compensatory mechanisms that the body tries to use. And then there's also metabolic or chemical regulation that typically occurs as well, and this is constriction or dilation of the vessels in response to levels of carbon dioxide, mainly in the blood, as well as oxygen. And so one of the things we know is carbon dioxide, or that CO2, is a very, very potent vasodilator. And so when we start looking at interventions and things like that with our patients that have ICP problems, maintaining their CO2 levels at a lower level becomes very important, because if you have vasodilation going on, particular cerebral vasodilation, you're going to have a lot more blood flow going to the brain, or those vessels will dilate. So what's going to happen is you're going to have more increased intracranial pressures. So when people become hypoxic, or more important, they become, have hypercapnia, where the the CO2 levels are really high, then they get acidotic, that CO2 level goes up, you have cerebral vasodilation, which increases that blood flow, and that just increases the edema within the brain, which then increases the ICP, and then it just becomes this vicious cycle. So maintaining good oxygenation and keeping a lower CO2 level with these patients becomes very important. And so when we're looking at nursing interventions, you'll see them monitoring ABGs very closely. They may be keeping the CO2 levels, lower than even fall into normal parameters, because your normal CO2 on a ABG is 35 to 45. You may see them keeping them closer to 30 to 35 for these people with increased intracranial pressures, because we know that CO2 is such a potent vasodilator, and we don't want to increase that cerebral vasodilation, which will increase the edema, which then again increases that ICP. So just something I want you to keep in mind with patients with head traumas is maintaining good ABGs and making sure that they do not start retaining too much CO2. Okay, and then the last dish effort that the body tries to do for compensatory mechanisms is something called herniation, which is really something we don't want to see. We try to avoid this at all costs. And this is just basic, where the pressure in the cavity exceeds the normal compensatory mechanisms, and the brain escapes by displacing downward onto the brainstem, which causes cessation of flow, irreversible anoxia, and brain death. So we do not want this happening, but it is the body's last ditch effort. I shouldn't really say that. It's just there's so much pressure within the cranial vault. And when you think about it, the only place it has to go is down. That's the only avenue of escape from this high pressure area that's occurring, because it can't go up, it can't go to the sides. The only thing it can do is go downward, and so it does. It pushes downward, displacing downward onto the brainstem, which we know is not a good thing, because in our brainstem is our regulation mechanism that controls our breathing. We also have the vagus nerve down there, which is going to stimulate, going to control like our heart rate. It can also, that's why sometimes, well, not at this point, but sometimes you'll see with patients with increased intracranial pressure, they'll have vomiting and stuff like that. That's from that vagal nerve being stimulated. But this is what we don't want to see. So we see two main types of herniations, and this is what your book talks about, is the uncal herniation or the central herniation. And you can see the difference here is the uncle, it's caused by a shift of one or both of the areas of the temporal lobe. Late findings of this include dilated or non-reactive pupils. You can have some ptosis going on and a rapid decline in your patient's LSE as this herniation is occurring. The central herniation is caused by a downward shift onto the brainstem. And so you would expect to see, because again, think about what's being housed in your brainstem. Findings include those Cheyne-Stokes respirations, where they'll have rapid breathing followed by periods of apnea. They can also have pinpoint and non-reactive pupils as a sign of central herniation. You'll start to see things. We're going to talk about posturing and stuff like that. It's usually a process. Somebody doesn't go just from like, hey, I've got some increased intracranial pressure to herniation in a matter of minutes. This is a process that takes a while for it to occur. So you'll see this process, start and just progressively decline. So you'll see different things in your patients, but the herniation is the last effort of compensatory mechanism. But if we start to see signs of herniation, like some of these things that you're seeing, that to us, it is a life or death situation. We need to do everything we can at this point to try to relieve the ICP and get it to go down. So hopefully we can avoid death for this particular patient. And we've established I'm a picture person. I'm very visual, so pictures always help me out. So this is just showing you what the normal position of brain tissue would look like. And then we have the picture on the right that shows position of brain tissue with herniation. And so you have that central herniation coming down onto the brainstem, and then as well as this uncal herniation, just kind of showing you the different different types of herniation that can occur. In this particular, it looks like the one has a tumor growing. Not that that's important, but this just kind of gives you that image of what happens when the brain herniates. So what will you assess, or what are those early changes that you will see with increased intracranial pressures? Well, probably the most obvious and one of the first things that you're going to see is some changes in your LOC. So some disorientation, maybe restlessness, agitation. You will see a change in the LOC, and that's why it's so important when you have somebody who has had any kind of head trauma, any kind of brain bleed that you're aware of, and you're doing monitoring, you're doing those constant neuro assessments on them. You want to make sure that if they become restless, confused, any kind of problems with their LOC, that you're on top of it, because those are signs that you've got some increased intracranial pressure going on. They may have some increased respiratory effort, having some difficulty breathing. You might see pupillary changes. They may be pinpoint, one might be blown. You could have one not be reactive. They may both not be reactive, but you'll start seeing pupillary changes. You may start seeing weakness, particularly one-sided. If you think about our stroke patients, people can have hemorrhagic strokes or bleeding into the brain, so you can see weakness developing as well. They may have a constant headache that's increasing in intensity, getting worse and worse and worse and worse, aggravated by movement, particularly if they put their head down more in the morning. And that, when we think about it, that has sometimes to do with, I think of things like brain tumors in particular, people who have headaches upon awakening on a regular basis. That may be a sign of a brain tumor, and that occurs because you don't facilitate drainage when you're laying flat. When we're talking about the ICP, particularly, normally you have the CSF, which can regulate itself by maybe draining a little more into the spinal canal and stuff like that. Well, if you're laying flat, that inhibits that ability of the CSF to drain, and so when that happens, you will have an increase in intracranial pressure. So those things like that can affect that as well. Nausea can happen. Seizure disorder can happen. I shouldn't say disorder, but seizures can occur with increased intracranial pressure. And then we go back to that Glasgow-Coma scale. A decreasing number on that scale is an indication of ICP. And so when I talk about the Glasgow, think about that it monitors those three things, and go back and look at that. I don't feel like I should have to review all of that with you, but do you understand, that you're checking for that eye response, that verbal response, and that motor response? Your top number is 15. Anything below 8 is considered the patient is comatose, and anything below 3, the patient is basically unresponsive at that point, and that usually does not have a good outcome as well. Doesn't mean it's the end, but usually GCSs of 3, you get kind of worried about long-term what the patient's going to be left with after that. But these are just some of the early things that we see. The later changes associated with increased intracranial pressure, again, you will see even further changes in LOC. So you go from having a patient who is maybe just confused and agitated to unresponsive. Papillary edema or choked disc, that's always a sign of increased intracranial pressure, and that basically is something that you probably would never do as the registered nurse, because this requires an ophthalmoscope, but you would actually look in the eye and you would see that disc swollen in the back, which should be a nice clear borders, and it almost gets kind of a hazy look as you're looking through it with an ophthalmoscope. I don't care that you know how to assess that, but just know that if you see that papillary edema, that is a late sign of increased ICP, not something that you want to see. And then we have something called Cushing's triad, which I'm going to talk about on the next slide a little bit more in detail. You'll see respiratory pattern changes. I wrote on here to review your respiratory patterns. So things like the Cheyne-Stokes respiratory patterns can start to come into play here as those ICP numbers go up. Elevated temperature, not uncommon to see that, and then eventually they will become hypothermic. But one thing to keep in mind is when you have an elevated temperature, that also can increase your ICP. So being able to monitor temperature closely on patients that are having ICP problems, and maintaining and trying to intervene and keep those blood or the body temperature down at a normal temperature is important for these patients to help regulate that ICP. You'll have a loss of reflex, so pupillary response will not be there. They may lose their gag reflex, so you have to worry, about choking. You may have to do some suctioning and stuff like that because you don't want them gagging. Projectile vomiting without nausea, so they won't even feel nauseous. They'll just projectile vomit on you. Again, this goes back to stimulation, or I should say that pushing down on that vagus nerve can cause this. And then we can have posturing that can occur. And I've got a slide, I think it's a couple down, that talks about the different postures. This is something that we talked about in third semester about the posture, but we'll review that on a slide here coming up. Okay, now we're going to talk about Cushing's triad, and this is something I'm going to tell you that you're going to need to understand as we're talking about ICP, increased ICP. This is something we do not like to see. It is a classic light sign secondary to ischemia, causing peripheral vasoconstriction. And what this causes is it causes severe hypertension. And when I say severe hypertension, I'm really talking more about the systolic number being very elevated. And then what you'll see is that top number, that systolic value, will be really high, but the diastolic won't necessarily change. And so what that creates is that widening pulse pressure. Normally if I told you a patient had a blood pressure of 100/60, that pulse pressure is the difference between the systolic and the diastolic. So your pulse pressure is 60, because you have 100 minus, it should be 40. 100 minus 60 is 40. So your pulse pressure would be 40 for a blood pressure of 100/60. So in this case, what you're going to see is that systolic number might rise to 200, but that diastolic may still stay at 60. So then your pulse pressure becomes like 140 as opposed to just 40. So you start seeing that increase in your systolic pressure, widening pulse pressure, and then also bradycardia. And this typically happens because if you think of your herniation occurring, and I've already told you that you get, when that brain starts to come down, it puts pressure on the vagus nerve, and that vagus nerve helps to innervate or regulate that heartbeat. So that can cause that bradycardia. It does say in here that's not often, the bradycardia is not often seen in children, but these three things are that kind of comprise this Cushing's triad. Now, the one thing I will tell you is some of the sources will differ, and I have seen this on many, but some of them will also talk about irregular respirations as part of this triad as well. So if you see a question that talks about ICP, increased ICP, or you're regulating ICP, and they give you, vital signs or respiratory patterns, and they tell you that the patient is having irregular respiratory patterns as well as low blood pressure, low heart rate with a widening pulse pressure, those are all things that you need to recognize as late signs. But Cushing's triad usually are these three things that you're seeing here because of the cardiovascular changes. These things all indicate that death is imminent when we start to see this. So this is one of those things we see right before the patient expires. So this is a very late sign, a very ominous sign if we start to see these things occurring in our patients. This slide here is a review from third semester. This is just talking about your different types of posturing or abnormal posturing. The decorticate or decorticate. Remember, everything comes to the cord or to the core, to the central part of the body. So you'll see those arms start to draw up. Then you have decerebrate or decerebrate posturing, where everything kind of extends away from the body. And then they go to the flaccid, where they just are kind of limp. And like I've told you before, this kind of progresses in a pattern from the decorticate to the decerebrate to the flaccid. So we need to, as nurses, start to realize when we see our patients start to do any kind of these abnormal posturings, especially to corticate, because that's the one we're going to see first. If we start to see our patients do this, this is a sign to us that there's something wrong, that pressure is going up, and I need to be doing some further assessment, and I need to start intervening on this patient. Because if I don't, those pressures are going to continue to rise. And when that happens, the brain will not be perfused. The patient can suffer irreversible brain damage, and that leads to poorer outcomes or even death for our patient. And I know I probably told you in third semester, but this is one of those things with Susan's daughter that luckily they were paying attention because she started to posture when she was in the hospital, and they quickly recognized it, they quickly intervened, and they were able to fix the problem, which saved her life. So good nursing, good observation, good assessment skills so that you can quickly decide what's going on so you can get those interventions quicker, because time is brain when you're looking at any kind of neurological processes. So your job as a nurse is so important here. Okay, so now that we have looked at what ICP is and some of the clinical manifestations, we're going to take some time to just kind of look over some of the lab and diagnostics associated with a patient who has increased intracranial pressures. So we talked yesterday in class in our little case study about CO2 and its effect on ICP, so it would make sense that we're going to be doing ABGs, and just to make sure that the patient is not having any increased CO2, because we know CO2 is a very potent vasodilator. CBC chemistry panel, and they may do cultures as well. Now this would be something you have to remember, that people with ICP may also have something like meningitis or encephalitis, so they would be doing things to rule out infectious processes and to isolate potential pathogens that they may need to be treated with antibiotic therapy. The serum osmolality, you can read the reader notes below. This is something that they use. One of the drugs that they give for ICP is called mannitol, and one of the ways we check its effectiveness is by monitoring this serum osmolality. CT, MRI, and PET scan, well, that kind of makes sense. It's going to give us a better picture of the actual brain itself. And it will also help us determine ICP if we're starting to see manifestations as well. Transcranial Doppler, that's something that is used to help with looking at the blood flow within the brain itself. So that becomes important. EEGs, you guys are familiar with. You see these done, people who have seizure disorders and evoked potentials. These are just looking at the electrical conduction within the brain itself. One thing to note, and this is, when we start talking about people with meningitis and encephalitis, and we're looking at doing lumbar punctures to assess the CSF, one thing to keep in mind is if you have a patient who has increased intracranial pressure, you do not want to do a lumbar puncture on this patient. Kind of think about it as like popping a balloon. You have a lot of pressure in there, you put a needle in it and it pops. The same thing can happen here. You put the needle in, you change the pressures, and it literally will cause the brain to herniate downward. So on somebody who has increased ICPs, you want to avoid the lumbar puncture. And then of course calculating the cerebral perfusion pressure if you have a monitor in place. We kind of talked about that in length yesterday. So ICP monitoring, this is where they're actually going to monitor those intracranial pressures, and this is performed by placing either a screw, a catheter, or sensor through a burr hole that they make into the cranium, and they usually place this in a ventricle, so arachnoid, epidural, or subdural space, depending on what area of the brain they're trying to monitor. This usually is then covered with a dressing that you will have to be monitoring. Be sure to provide a head-to-toe assessment. Even though the patient's ICP is being invasively monitored, you still need to be paying attention to those subtle cues that we talked about in previous slides, those early and late signs of increased intracranial pressure. And so I've referenced back to the chart in IGGI on page 936, this chart 45-6, because it goes over the key features of increased intracranial pressure for you guys to review. Okay, so when we're looking at ICP or increased ICP, we always want to assess those things that can cause it to go up because we want to avoid those because we want to maintain a good pressure within the head. So hypercarbia, or that increased CO2 level, I think I've beat a dead horse here with telling you that it's a patent vasodilator, but it is important to know that CO2 can have a significant impact on your intracranial pressures. Endotracheal or oral tracheal suctioning, there's a couple different things here that this can affect, why this can affect your ICP. Number one is when you suction, you tend to lower somebody's O2 or drop that down, which can put them at a higher risk for ICP as well. But also, it's very common when you suction somebody for them to cough. So you can see down below, coughing is one of those things that increase intracranial pressure. Just think about it. When you have the flu, you kind of get this horrible headache, and then you start coughing, you kind of feel like your head's going to explode. So we know that coughing does increase that ICP. Extreme neck or hip flexion or extension. We talked about this a little bit yesterday. That's why maintaining that good body alignment, the head in a neutral position, so there's no neck flexion going on or extension. And also when you elevate the person, to maintain the head of the bed at 30 to 45 degrees, some will say 30 to 35, but the main thing is you don't want to lay them flat typically, because you want to be able to drain, have facilitation of drainage of that CSF, but also you don't want to put them too high, because if you do that, you cause that flexion in the hips, and that can increase your intra-abdominal pressures, which it can in turn increase your ICP. And it says down below, increasing intra-abdominal pressures. So things that will increase that, trying to keep the patient on a regular bowel maintenance, giving them something hopefully to, keep that going. A lot of these people will be on tube feeding, so hopefully, constipation and stuff like that won't be a big issue. But as they begin the healing process, we know that they've had this brain injury. We don't want to do anything that could potentially cause them harm. So, a good regimen for bowels after that is part of that maintenance there. Okay, so looking at nursing care, like an overview of nursing care, and we're going to kind of break this down here a little bit on some of the next slides. You always want to compare your baseline to your desired. So you want your ICP, we've discussed this, below 15. You want your MAPR, that mean arterial pressure, to be about 80 or greater, because we want to make sure that things are getting perfused. You want that cerebral perfusion pressure between 60 and 80, in that range. So you want to maintain your systolic pressure above 100, but you don't want to exceed 160 because you don't want it too high, because you don't want to cause any further damage to the brain tissue. Performing frequent neurological assessments, you're always comparing those to baseline, and that's why it's important to get in there, get that first assessment done, so you know what your baseline is for the day, so you can determine if there are any neurological changes that would indicate the patient's declining, so you can come in and intervene. Hopefully you'll see improvements because your interventions are being successful. Look at your vital signs, look at those trends. We talked about things that can start to happen as that systolic pressure rises and you have that widening in your pulse pressure. You may see the patient become bradycardic. Respiratory changes, are they in a regular respiratory pattern, or is that changing? Temperature is something that you want to monitor very closely, because we know with fever we have an increased metabolic demand, and that can affect outcomes for the brain tissue. And then timing of care. Casey did a really good job yesterday in class talking about this. You want to kind of spread it out. Sometimes we kind of like to group our care together so we can get in there, get it done, and then leave the patient alone. For these patients, you don't want to overstimulate them, so timing of care is important. So you may need to just go in and do one thing and then give them time to rest. Go back in and do something else, give them time to rest, because you don't want them overstimulated, because that can cause a rise in ICP. And then, one of the things we do as nurses with patients who are suffering from a head trauma or having increased intracranial pressure from even meningitis, is a lot of patient and family education. It's a really scary time for them. And so just offering them, bits and pieces of what they can expect, what is going on. They tend to really want to hold on to hope. Sometimes you have reflexes that can occur, and they take that as purposeful. So a lot of education is important with these families. And then also provide the ordered treatments. You know, the physician will give you medications that you need to prescribe, something as simple as maintaining the head of the bed, but make sure you're doing those treatments as ordered by the physician or provider. Okay, so some other nursing care associated with increased intracranial pressure is, and we've talked about this, ABGs and keeping that O2 up, because we know high CO2 is not a good thing for these patients, and a low O2 is also not good because that tissue still does need to be perfused to save it. So our goals are to try to keep our O2 sets above 92, and when you're looking at your ABGs or those blood gases, you want your PaO2 to be between 80 and 100, which is in a normal range, and your PaCO2, or that CO2 level, to be, normal is 35 to 45. One reference I saw said 35 to 38. That's where this comes from, but I have seen some references that also will tell them to even let it be lower than that. So even out of range, you lay down around 30 to 35, because we want to maintain as much control on the ICP, and knowing that CO2 can cause an increase in that. And then also hemoglobin above 10, because like I said, we're still trying to perfuse that tissue. So we need that hemoglobin to be our oxygen carrier. So you want to maintain their hemoglobin above 10. Some other things we do is you maintain your vent setting, your partial pressure of arterial CO2. Again, you want to keep that CO2 level down, because we know that it does cause, this is vasoconstriction. I just realized that it should say vasodilation. Or decreased, I say it now, decreased CO2 is vasoconstriction, increased is vasodilation. I see what I've written there, sorry about that. And evidence-based practice does tell us to avoid prophylactic hyperventilation. We talked about hyperventilating the patients when you're suctioning them, but within the first 24 hours, they actually recommend that you don't hyperventilate the patient. After that first 24 hours, you can, but they do recommend that you not do it in the beginning. And then the other thing is you don't want a high PEEP setting on your patients who are vented. So, these patients, when you have them on the vent, you'll see that PEEP set about at 5, because you want to maintain the openness of those airways, but you don't want the pressure so great in the thoracic cavity that you in turn are then causing greater pressures ICP-wise. Pulmonary hygiene, so prevention of any further problems with the lungs, which can affect the respiratory system, which then can affect your O2 and even more buildup of CO2. So that's why this becomes important. So positioning, we know usually we like to sit people up, but keep in mind we have somebody with an ICP problem. So you do want to keep them at least 30 degrees. So we've said that 30 to 45 is kind of a good window for where you want patients with ICP problems to sit. You do want to minimize how much suctioning that you do have to do. When you do it after that 24 hours, you do want to do good hyperoxygenation. Aspiration watch, you don't want them to, choke on anything. That's where suctioning becomes kind of an important part. And you are going to assess your lungs at least every 8 hours. You may do it more frequently if you're seeing that you need to do that. Some institutions will have you use lidocaine to suppress that cough reflex, because keep in mind, coughing increases that intracranial pressure, but you just have to be careful with that, because if they can't cough, they can't clear their airway. So that's where you're going to have to be extra vigilant if you use that, to make sure that airway stays clear and open for them. And then again, preventing abdominal distension. Okay, and kind of talked about this already, but it is very important to regulate their body temperature, because we know hyperthermia, or an increase in temperature, does increase, the oxygen or the demands, metabolic demands, which can lead to an increase in poor outcomes for our patients. So this is a defense mechanism, usually from trauma, infection, or hypothalamic damage itself. A trauma response, you're going to have inflammation or an inflammatory response going on. So you can see here that each degree the temperature goes up, it does increase the demand for oxygen, which is something we don't want, because we need to keep these people oxygenated as much as possible. One thing to note here too is the hypothalamic associated fever is high and lasts for several days to weeks, and this is typically manifested by an absence of sweating. So they'll have a high temperature, but you won't see sweating associated with this. One thing that they do occasionally do with these patients, and you'll see this also with some of your heart patients after an MI, is that they will use a hypothermia protocol to lower the metabolic demands to try to preserve function. If that is done, just know that rewarming does require specialized knowledge and skills. It's usually done with a protocol that's used throughout the institution. You don't have to understand that. Just know that it is a specialized thing, and you just can't go, hey, I'm going to warm you up today and just crank up some stuff and get them warm real quick. It takes several hours. Usually it's about a 24-hour process or longer to actually warm somebody up. And again, that fever for many causes associated with higher morbidity and mortality. So it's really important for us to try to regulate and maintain a normal body temperature as much as possible. But keep in mind, sometimes we just can't. Sometimes the damage is just so great that these patients will start to get a fever and there's nothing we can do. I mean, I've seen some people head trauma-wise that their temperatures were 105 and 106. Because of the damage done to the hypothalamus. And unfortunately, it did not have a good outcome for these particular patients, but it is something that you do see. Additional ICP, or increased intracranial pressure nursing care, positioning. Again, I feel like I've talked about this quite a bit already. You know, I did mention this in class yesterday that anytime you have somebody that suffers a head trauma, you need to make the assumption that the patient may also have a cervical neck injury. So you always want to watch for your positioning, no pillows, no neck rolls until your spine has been cleared. Like I said, you want to maintain cervical spine precautions until you can actually clear the neck. Head of the bed, we've talked about this, I feel like 100 times over, and that neutral alignment. And again, we do this because we know it facilitates drainage, but it also helps to decrease that intracranial pressure, keeping them in a neutral line with no hip flexion. You do still need to worry about your skin, assess your skin. Keep in mind, you know, if the patient were to develop a wound that would then get infected, that also increases metabolic demand. That can increase the potential that the patient could have a fever. And then we have the other vicious cycle starting now that we have an increased oxygen and increased tissue demand metabolically from another source, and we just don't need the extra headache. So these patients you will turn, but you have to do it very gently. You may have to log roll them. Sometimes you do this. They definitely are a sedation at times to do this. When the patient is, you know, alert, you do want to avoid having them help you. You just let them kind of rest and relax. You think about when you move and you push up on your hands and all the different things we do. A lot of times people will kind of hold their breath when they do those kinds of things. So just kind of picture yourself sitting, kind of trying to lift up. You can see how that can increase pressure, like abdominally or intrathoracically. So that's why you just kind of want them to just kind of lay there and let you do the work for them for a while. I think the salva maneuver, that should make sense to you guys already, that's going to increase the pressure in the abdomen. Passive range of motion. Some of these patients may be sedated or maybe in a comatose type state for some time, but that doesn't mean they're going to stay that way. So we need to make sure that we're keeping those joints and muscles and stuff like that active and moving so we don't wind up with contractures. Again, I think about Susan's daughter, and I know they did a lot of this with her. While she was not able to do this for herself, to help make the rehabilitation process easier than it already, you know, with the difficulties she was already going to have. It did make it easier and helped her to recover more quickly. So some other things, skincare. You should be thinking about that anyway. When you stop and think about any patient that's immobile, you should always worry about skincare. So what are you going to do about it? Yeah, you're going to turn them. You're going to think about getting the heels elevated, but you also need to consider proper hydration, proper nutrition, and all those other things that go into skincare, keeping it clean, not wet, those kinds of things. Rest periods, I think we've talked about this quite a bit too. Just having the ability that when you do your care, you can't bundle it. You need to do something, leave them alone, go back, do something else. Something as simple as, giving them a bed bath and changing their bed may be a several hour process because you need to do one thing at a time instead of just going in and doing all that AM care at one time. You can't do that with these patients. You have to allow them those rest periods so that you don't overstimulate them. Compression boots or those SCDs, because you do have to worry about these patients being immobile, that they could develop DVTs. So they may be on anticoagulant therapies for that. PT and OT are probably going to work with them to help regain their physical mobility, but also OT may need to come in to retrain them to, learn how to eat. Simple things like that. So some more nursing care for increased intracranial pressure. We always want to monitor infection risks. Talked about that just a little bit on the last slide with infection to the skin, but also keep in mind if they have monitors in place, those intracranial monitors to measure that ICP, or because of a trauma-related injury, maybe they've had an open trauma, we want to make sure that we're doing good scalp care and assessing any drainage, if we should see any. Is it CSF? Is it blood? Do not pack the nose or the ears because we want some of that to drain, but we don't want to cause, kind of give it the medium for growth for infection. Prevent contamination, assess for signs and symptoms of infection. I'd like to think you guys know that by fourth semester, redness, warmth, monitoring your CBCs, drainage, like I said, what does it look like, that coca? You may be giving antibiotics as ordered. This is not uncommon to do a lot of prophylactic type antibiotics if you have somebody with an open wound, just because if it's from a trauma-related incident, we don't know what could have gotten in there, so they will do a lot of antibiotics prophylactically for that. These patients are at a risk for seizure with increased intracranial pressure, so you want to have your seizure precautions in place. So, darken the room, quiet rooms, pad their rails. You want the rails up. You may have them on medication, some kind of seizure type medications to help with that. Okay, so now kind of looking at like the GI nutrition part of nursing care for increased intracranial pressure. Very common that these patients will have some kind of tube feeding going. They typically are NPO. You will replace fluids via the IV system. You do want to weigh them daily to make sure that you're having a positive balance. They may have an NG placed or an OG during the acute phase, and the reason I put OG here is, if you have a patient that comes in with head trauma, you're real reluctant to drop an NG tube down somebody who you think may have, skull fractures and things like that. So there may be an OG in place here. Watch for GI irritation, ulcers. We talked about this yesterday in our case study. The patient had famotidine ordered for prevention of peptic ulcer diseases. You also want to monitor their blood sugars because you may see a drop in this as well. Bowel programs assess your INO. You're going to look for distension and constipation. Like I say, we don't want anything that can possibly increase the GI pressures, or I should say that intra-abdominal or thoracic pressures. So constipation is something that can do that. So we want to assess for constipation as we go through this process. And then also they may be on stool softeners to keep those stools regular, so we don't have to worry about them bearing down and performing that Valsalva basically that could increase their intracranial pressure. Moving on to the GU or the genitourinary systems, looking at increased intracranial pressure nursing care. You do want to assess the bladder for distension. You may also want to do like a bladder scan to see if there's residual urine in place. Oftentimes they will have a Foley placed depending on how significant the ICP is. Because if you think about it, these patients are basically comatose and you don't want to run the risk of skin breakdown, but you also have to be very, very careful and do good Foley care because you don't want additional infections. going on. Creative maneuver is mentioned here to help them empty it if they're having a hard time like innervating that themselves. And that's where you actually push down on the bladder through the abdomen to help them empty the bladder out. You do want strict INO. You're probably going to have 2 large bore IVs for these particular patients. You do want to keep that CPP, or that cerebral perfusion pressure, between 70 and 80, so you may be giving a bit of fluids to help try to monitor and regulate that. Too many fluids, though, you can increase the risk of them developing ARDS. One thing to note here is people, with head trauma, you see this sometimes with people with brain tumors, because it does, if you think of a brain tumor, it's adding more mass to the brain, so then we wind up with increased intracranial pressures. So this is why this is one of those risks. They can develop SIADH, or that syndrome of inappropriate antidiuretic hormone, or diabetes insipidus, which that also occurs because of that antidiuretic hormone. Syndrome of inappropriate antidiuretic hormone is just what it says. The pituitary releases way too much SIA, or that ADH, and so the body then maintains or holds on to its fluid. And so what you see with there is you see dilutional serum sodium. So you'll see a dilutional hyponatremia occur with someone with SIADH. And then with diabetes insipidus, it's the absolute opposite of that. The brain's not releasing the ADH, and so therefore the patient, you will see them eliminate massive amounts of fluid, like up to 10 liters in a day. And so when that happens, then you get hypernatremia because they're so depleted of water. So these are just 2 complications associated with increased intracranial pressures. And both of those are mentioned really, really briefly. There's just a short, tiny paragraph in your ATI book on page 85, and that's the ATI Medical Surgical Nursing book that just kind of touches on that just real briefly if you want to take a quick look at it. Finally, we're going to look at some of the psychosocial aspects of increased intracranial pressure nursing care. And already mentioned this one, but it's you must support the client and the family. This is really kind of a very, very scary time for a lot of people. We think about our loved ones, and the thing that makes them who they are a lot of the things that are stored in the brain, or those functions that come from the brain that kind of makes the personality, that makes the person. And so this is a really scary time when you're dealing with somebody who has intracranial pressure problems, because you're worried, number one, are they going to survive? And if they survive, what quality of life are they going to have? And are they going to be the person that you've always known? So it's a really scary, scary time for families. Also, some things you want to do with the patient is assess for coping. How do they view their body? Sexuality changes. All those things that can be affected when you have a change in your brain function. Age does play a role. You think about it, somebody who's older, they may have physical limitations to begin with, and now we've added this to it. So their coping may be more dealing with the physical aspects of the brain injury, whereas somebody who is young, it may totally disrupt their social pattern, their relationships. So there's just a little bit different focus depending on their age and what role they're in. Again, somebody who's older that's a grandparent, yes, that affects them. But what about a young person who's a very young mom or dad who no longer can care for their child for a period of time while they're rehabilitating? So that can be very, very difficult. So we do want to assess their coping. Short and simple explanations are always better. Give them short. If you need to give them a long list of instructions, give them to them 1 or 2 at a time. Let them complete that task and then give them the next step. Don't go rattling off 10 things you want them to do, because there's a good chance they won't be able to do it all at once, and then they're going to become frustrated. You do want to get them to participate as much as possible, and sometimes this is difficult, especially if this causes some kind of like depression in them, they may feel very helpless and hopeless. And so sometimes just getting them to participate in their own care can be difficult, but you want to encourage them to do that because as they start to do it, they'll gain confidence. Know your resources. And then make referrals. You know, they may need home health. They may need occupational therapy after this is all done. They may need speech therapy after this is all done. They may need, financial resources available to them or retraining for a career or a profession. So know what resources are available and then make the referrals as needed. This is a really good place here for your social service people to get involved into your patient care. Do some of that interdisciplinary, with social services, your OT, PT, speech therapy, that kind of stuff. So some pharmacology or pharmacological agents that are used to help with regulation of increased intracranial pressure are things like some of your steroids like methylprednisolone or dexamethasone. And one thing to note here is that they typically are not really helpful in ICP caused by injury or infarct. So these are things that would be used more for like meningitis to help decrease, the inflammation of the meninges, kind of thing. Osmotic diuretics, this is probably one of the most commonly used one, is mannitol. And your book does a good job talking about mannitol. On page 948, it talks about how it needs to be given through a filter because if you've ever seen it, it forms like little crystals. So that's why it requires a filter needle when you're drawing it up. It also requires a filter in the line too as you give it. So it's just one of those things that are it's kind of a cool drug when you look at it in the bottle when it's got the crystals, because it looks like it's got like icicles all over inside the bottle. So anyway, mannitol is something that's often used to help decrease the swelling that's going on. The goal here is for the serum osmolality be between 310 and 320. And if you think back to the slide where we had the diagnostics, we mentioned that would be something that they would monitor to determine effectiveness of this medication. You do need to watch, however, your serum electrolytes, because this can affect both your sodium and your potassium, causing your sodium to drop and your potassium to go up. So you do want to be able to monitor those things. They will use sedatives. Most commonly used one is propofol, and that's one we talked about yesterday in class. That's the white one. Yes, they do need to be on a ventilator for this. Anti-epileptic drugs like phenytoin is very popular one used. That's the one we used in our case study yesterday. They may use morphine as well to help with the air hunger. Aspirin and acetaminophen to regulate body temperature. Barbiturates to induce coma in clients with intracranial hypertension that cannot be controlled by other means. These are used quite commonly. It's almost like they use them to place the patient actually in a coma. And they do this because they want to decrease the metabolic demands, the cellular metabolic demands to hopefully help decrease that ICP. Most commonly used one is probably phenobarbital, and they do need to adjust these because you want the patient unresponsive because you want them to rest. One thing to note, if you're going to place the patients in a barbiturate coma to help them rest and regulate that cellular metabolism, the patient does need to be mechanically ventilated. They also need to have cardiac and hemodynamic monitoring going and ICP monitoring as well. Those things are required for a patient that you're placing in a barbiturate coma, but they will use these to induce coma in some of these patients to let them completely rest. So despite all our best efforts, there are those situations where the best nursing, you do everything you can. It is just never enough because it cannot fix everything. Nursing is grounded on some ethical principles of beneficence, which is doing good for the patient, and non-maleficence, where you're avoiding harm to the patient. And so a lot of times when we're looking at brain death and organ donation, those things kind of come into place. So is removing the organs killing the patient? In my opinion, no. I think most, and obviously state law kind of falls with this as well. We don't just remove or harvest people's organs while they're still alive. The patient has to actually be declared brain death. And like I said, when I talked earlier about, the thing that makes the person who they are those components that come from the brain. Everybody's heart beats the same. Everybody's respiratory system works the same for the most part. But all those little things that come from our brain that make us who we are, that's the part when that dies, that's when we consider death to actually have occurred. So, you might want to assess your own feelings or your own beliefs on, do you think you're killing somebody by taking their organs? Or do you think at this point, the patient no longer is alive when brain death occurs and it's okay to go ahead and take those? So organ donation is a moral duty, or is it a moral duty or obligation? And again, that's something you're going to have to ask yourself, to kind of search yourself for those answers, because at some point, depending on where you work, if you work in critical care areas, you're probably going to be faced with these very questions. So it's just something to think about as we're going through this process. So what kind of criteria do we look at when we're assessing brain death? Well, brain death is the permanent loss of all brain function secondary to a loss of cerebral flow. And I can tell you a lot of times when they're doing this, they will do like CTAs to determine flow to the brain. And a lot of times with these patients, what you'll see is the blood flow only goes up so far into the carotids, and then it just ceases to flow to the rest of the brain when you're looking at these tests. The criteria does vary per state and by some facilities. However, most institutions do base their criteria from the American Academy of Neurology, or that AAN. The original criteria was done in 1995 and it was updated in June of 2010. It has not been updated since, so this is the most recent and current updates and versions of what the AAN says about brain death. So absence of clinical brain function when the cause is known and irreversible. So we know what caused it, and we know that no matter what we do, we're not going to reverse the damage that has been done or get that function back. There are 4 prerequisites for somebody to be declared brain dead or have brain death. Coma of known cause. Again, that goes back to that very first thing. Normal or near normal core body temperature. So you need to have kind of things at a normal, everything else regulated in the body with no brain function, okay? Normal systolic blood pressure or greater than 100. And 1 neuroexam. Some facilities or states may require 2 to determine brain death. These are the 4 criteria or prerequisites used to determine brain death. I would tell you that you do need to know these. I don't know that I will necessarily test you on this, but I have seen these types of questions in NCLEX. So understanding those 4 prerequisites for brain death are important for you to know as a nursing student and a nurse. Okay, so once that prerequisite criteria is made, this is where that last one they're talking about, somebody comes in and actually performs the brain death exam, and this could be done by 1. Some states will require 2, or facilities require 2 physicians to actually do this. So they'll look at things like pupillary response. You guys do this all the time with your neuro assessments. You shine that light in there. Do the pupils react, or are they fixed? Corneal reflex, taking and wisping something across the cornea. Cough reflex, they try to elicit a gag reflex in these patients. Do they respond to painful stimuli? Think about some of that GCS, can you get the patient to move or do anything to painful stimuli? The oculocephalic, or that doll's eyes, we talked about this real briefly yesterday, where they'll take and turn the head, and do the eyes stay fixed or do they rotate? That's another test that they do. Cold caloric, that's the one that Stacy talked about in class, where they take the ice cold water and they squirt it into the ears while watching the eyes to see if there's any response to that. That's kind of a very only word I can think of is kind of a primitive stimulation that will occur if there's brain function. If they don't see that, that's a good indication that the brain is no longer connecting and working properly. So the brain is now, like I said, disconnected or there's brain death. Neuroimaging is not required but recommended, and that's like the cerebral angiography, EEG, or the cerebral computed tomography, angiography, and that's that CTA. And that's like what I talked about, where they'll actually inject dye, kind of like you would a heart cath. And instead of tracing the blood flow through the heart, they're tracing the blood flow into the brain. And a lot of times on these, what you'll see is, like I said, the blood flow will go up into the carotids and then it just stops. So when you're looking at the brain, there's like really no flow going back into that brain. So that's just another test that they may do. Okay, so now that we've talked a lot about ICP, increased ICP, we're going to look at some of the processes that can cause intracranial pressures to rise or to be increased. The first one being a traumatic brain injury. And that is basically just damage to the brain from some kind of external mechanical force. It's not caused by any congenital or neurodegenerative processes. It's something else that's external that has caused this to occur. Generally, it's like a blow or a jolt to the head. So MBC, falls, motorcycles, bike rides can result in this. Playing sports, certain sports could potentially lead to this. So it's basically anything that can, cause a blow or a jolt to the head. And it can also result from head penetration by a foreign object. So that would, a bullet, a knife, a stick, anything like that can also cause a traumatic brain injury. And then yesterday in our case study, we talked a little bit about primary brain injury versus secondary. The primary is, the initial insult or event that occurred. It can be an open or a closed head injury, with it being just what it says. Closed head injury is like you hit your head, the skull is intact, but your brain has suffered a significant injury or damage inside. Open would be just that. You have a penetrating wound that you have an open area in your skull. The thing to remember when you're dealing with somebody with an open injury is that your risk for infection is something that you always have to worry about, because now you have an open pathway for some kind of pathogen to get in there and cause infection. They can be mild, moderate, or severe in classification. Fractures are a form of this as well, like a cranial fracture, basilar skull fracture, something like that. Diffuse axonal injury, that's where you have shearing occurring within the brain. And these are all talked about in your Iggy book in chapter 45. I think it's page 940, 41 or something like that. That you can kind of look at that a little bit more closely. And then your second injury, or the secondary injury, is the one that occurs after the primary injury and worsens or negatively influences patient outcomes. This is the one that we talked about, like the cerebral edema, things like that. These are the things that we try to prevent. It can cause by hypotension, because maybe you're not getting enough perfusion to the brain, hypoxia, the brain's not getting enough oxygen, increased intracranial pressure, like I said, edema, hemorrhage, too much cerebral spinal fluid, that hydrocephalus, or the brain herniates. These are all types of secondary injuries. And like I said, our nursing care for a patient who has had a traumatic brain injury is we're focusing on trying to prevent secondary injuries from occurring. And if they do, like sometimes you can't help but the ICP because of the edema and stuff like that goes up. But how do we manage it to keep it so that we have as little permanent damage as potentially there can be for this particular patient? And since I love pictures, I had to throw in one that just shows you some different types of traumatic brain injuries that can occur, this coup contra coup, as well as this acceleration, deceleration injury. Again, your book does a nice job discussing these on page 941, so if you want to review those, you can. like I say, these are just two types of injuries, so you may hear these, you may see these in dictations. I've seen coup contra coup before in physician dictation or provider dictation, but these are just two different types of forces that can lead the patient to suffer traumatic brain injury. So this is just a real quick look at some of the different types of hemorrhages or hematomas that can occur. I know when I very first started teaching, head trauma, brain bleeds and stuff like that, we really focused in on the different ones quite a bit, but anymore we don't, because really the most important thing for you to understand is how do you take care of it, because a lot of times it doesn't really matter where the bleed itself is, the care stays relatively the same. But just I want you to be familiar with some of the different terms, because you again may see these and then kind of gives you an idea of where these head injuries are occurring. And again, Iggy does kind of go over these, kind of gives you some pictures that you may want to look at on page 942 and 943. But you have an epidural hematoma, which is a collection of blood that's between the dura and the inner skull. And again, there is a nice picture here in figure 45-5 for you to look at. Subdural hematoma is exactly what it sounds like. It is a space between the dura and above the arachnoid space. So subdural, below the dura, okay? This is most commonly from tearing or tearing of bridging veins with cerebral hemispheres, or from laceration of the brain tissue itself. It usually occurs more slowly, and symptoms mirror those of an epidural hematoma. So this one comes on a little slower. Intracerebral hemorrhage is just what it says, an accumulation of blood within the brain tissue itself, and then you have subarachnoid, where you're having bleeding into your subarachnoid spaces. And this is just kind of being familiar with the structures of the brain and identifying where the different hemorrhages take place. So we're going to switch gears a little bit. We're going to talk a little bit about skull fractures, the different type of skull fractures that can happen with head traumas. So we have the linear, which is the most common, and this is just a simple, clean break. And I've got the picture here kind of illustrating these four different types to kind of give you a picture of what they look like. You have the depressed skull fracture, which is just what it says. It's depressed, it's pushed down, it's pushed in. Yes, we do have to worry when you have a depressed skull fracture, what structures has that skull now invaded with it going down into the brain cavity. Open is just what it says. It's open. You have an open area. Again, anytime you have openness into the brain, you have to worry about infection. That becomes a huge problem that you have to be worried about and be managing and taking care of. Communicated is kind of look at, you think about these fracture names, and you've heard some of these before in regards to regular types of fractures, in other places. So communicated just involves fragmented bones with depression into the brain tissue. Again, you do have to worry, where is that, where did all that bone go? What is it affecting? Do they need to go get it? Can they leave it there? Those kinds of things. And then basilar skull fractures, which we're going to talk a little bit more on some of the next few slides. This just puts the patient at an increased risk of hemorrhage associated with damage to your internal carotids, because it is at the base of the skull. This usually extends into the fossa, resulting in cerebrospinal fluid leaking from the nose and the ears, and that's why some of the testing we do when we suspect basilar skull fracture has to do with CSF fluid. These are the patients that you'll see the clear stuff running out of their ears or maybe out of their nose. So there's ways that we check to see, is that CSF, and we'll talk about that here in the next couple slides. And then basilar skull fractures can actually also result in some damage to some of your cranial nerves. So like cranial nerve 1, which is your olfactory nerve, cranial nerve 2, which is your optic, cranial nerve 7, your facial, and cranial nerve 8. That should be, I realize it says 7 and 7, but it should be cranial nerve 8, the vestibular cochlear. And if you want to know what those do, you can look down in those reader notes. It kind of tells you which each one of those does, which I like to think you guys should know. Olfactory has to do with your sense of smell. Your optic has to do with your vision. Facial has to do with innervating parts of the face, and some to do with taste. And then, of course, your vestibular cochlear has to do with your hearing as well as your equilibrium. But that just kind of gives you a quick rundown of what those cranial nerves do. So what do we assess or what do we see in the patient with a basilar skull fracture? Well, there's a couple distinguishing factors here. The first one is this periorbital ecchymosis or ecchymosis, however you want to say it, or raccoon's eyes, and then something called mastoid ecchymosis or battle sign, which I've got pictures of both of these on the very next slide. These are something when you see this in a patient involved in some kind of trauma, you have to suspect, could I have a basilar skull fracture on my hands? You might see rhinorrhea or otorrhea, and we often think of rhinorrhea like with runny nose, associated especially this time of year with sinus problems, but it just is running stuff out of the nose. That's what it means. It doesn't always have to be, sinus drainage, kind of things like that. They may have ringing or tinnitus in the ears, vertigo, so difficulty with their balance. And if you think about what I just told you on the last slide and at the very bottom here where it talks about cranial nerve compression, that cranial nerve 8 or that vestibular cochlear is part of your hearing and part of your equilibrium. So it makes sense that if that nerve is being impinged or having problems, that you're going to have ringing in the ears as well as issues with maintaining your equilibrium with vertigo problems. Epistaxis or that nose bleeding, and then hemotympanum, which is simply if you were to take an otoscope and look down into the ear canal, you may see blood behind that tympanic membrane. So those are all things that you might see as manifestations with a basilar skull fracture. Here you can see a picture is worth 1,000 words. I could try to describe that battle sign and raccoon's eyes to you, but I think having the visual of how they present is a lot more beneficial. So these are signs also, like I said, mentioned on the previous slide, a basilar skull fracture. So this is what those two actually look like, that periorbital ecchymosis and this mastoid ecchymosis, with battle signs being the one at the mastoid and raccoon being the one that's periorbital. Okay, so nursing care, how do you take care of the person with a basilar skull fracture? You want to do an assessment of that drainage, that clear stuff that are possibly runny, I shouldn't say runny, but bloody, that may be coming from their ears or from their nose. You want to assess that drainage for glucose using halo sign, which you can Google a picture of this if you need a visual, but usually you take like gauze or something and let it drain onto that, and what you'll see is the blood kind of goes to the center and then it gets a double ring around it that can be kind of a clear or a pink or a yellow kind of color, and that's called halo sign. You do want to keep the area and the dressings clean and dry because there is a very big risk for these patients with basilar skull fractures of developing meningitis, because now it has opened up a pathway, obviously, because we have CSF leaking. There is a pathway now available for pathogens to find their way into the meningeal area. Aseptic technique, if you have dressing changes that need to occur, you need to do that aseptically, again, because we don't want to introduce any kind of bacteria into that opening. You're going to be doing frequent neuro and infection assessments. I think by now you know how to do a neuro assessment. You should know how to do an infection assessment. So you're looking for redness, swelling, drainage, looking at your CBC, monitoring your vital signs, things like that. These patients are put on bed rest. Most often they are told to rest with the head of the bed at about 30 degrees. This has kind of gone back and forth. It used to be we used to kind of have them lay flat when they had a basilar skull fracture because of the leakage of the CSF, but now not so much anymore. It's kind of following increased ICP guidelines, but usually they want them at about 30 degrees. Medication-wise, they'll have something for the pain. They'll use the same medications that they might use with ICP or increased intracranial pressure going on, and then there will be antibiotics that will also be used for them, considering that they are at a risk for development of meningitis. Education is important with these patients. You can have a patient who has a basilar skull fracture that doesn't really require a whole lot other than monitoring, and they kind of heal up on their own. But you do want to tell them to don't do anything that increases pressure. So don't blow your nose, don't cough. They do need to kind of hold back their sneeze, so they may have to kind of close the nose down to prevent from sneezing because that may reopen that leak back up. Don't want to be suctioning the nasal areas. If they do not heal, they may consider doing a surgical procedure to kind of heal that up or to close stuff up within 1 to 2 weeks. And kind of like with any head trauma patient, you do want to wake them frequently to assess their neurological function. You don't want to just let someone lay there and potentially be having problems neurologically that we're not aware, because we think they're sleeping, but they're not really sleeping. They're becoming stuporous and stuff. So you do need to assess that neurological function. Okay, now we're going to change gears a little bit. We're going to kind of get away from head trauma and go into meningitis, which meningitis is just what it says. It's inflammation of the meninges. And it usually is most commonly caused by a viral infection. If you have viral meningitis, you just have to use basic standard precautions. This can be found in your EEG book, as well as in Chapter 5 of your ATI. They do a section on meningitis. And then also you have bacterial meningitis, which you want to use standard precautions. But the thing to note here is that for bacterial meningitis, you typically need to have the patient in droplet precautions. And so it's very common when you first have somebody present with meningitis that they put them in droplet precautions until they can rule out that the patient does not have bacterial meningitis. Once they can rule that out and say, no, it's a viral type infection, the patient will need to be put into droplet precautions because that is how this is transmitted. So just be aware of that. So these people will need to, if you take them out of the room, you need to have a mask over their face. If you go in the room, you need to have a mask over your face. So just be aware of what your precautions are for droplet precautions, and just know that bacterial, especially with the Neisseria meningitidis and the Haemophilus influenza, those will require that the patient be placed in droplet precautions. But we tend to always just make the determination until proven otherwise. It's kind of like a patient who comes in with TB that you suspect TB. You put them into those airborne precautions until you rule it out. With people with meningitis, you put them in the droplet until you can rule it out. So what are your physical assessment or clinical manifestations that you see in somebody who is having meningitis? Some general symptoms are just simply fever. Neurologically, they're probably going to have a headache, very, very common. They'll have photophobia or dislike of light. They may have photophonia, where they don't like sounds, which is not listed here, but that is something that they can also have. You may see indications of increased intracranial pressure, nuchal rigidity or stiffness of the neck. They may have a positive Kernig's and a positive Brzezinski's sign, which I'm going to talk about on a slide further on down in the presentation. I think it may be the next slide, in fact. Decreased mental status. They may have focal neurological deficits, so changes in their LOC, and they also may have nausea and vomiting from all that increased intracranial pressure, and headache can occur, so they can have some nausea and vomiting as well with this. They can also have, which I don't have on here, probably more of a general symptom, but they could potentially also have rash with meningitis, depending on the insulting agent that's causing it. So these are two tests that they perform when they're looking at potential meningitis, and then they're kind of looking at this nuchal rigidity. The first one being this Kernig side with the patient laying flat with their hips flexed at 90 degrees. The knee cannot be fully extended, or what happens is you may also see that it causes pain when you're trying to extend that out. It causes pain in the neck for the patient, so it becomes very difficult for them. And then also Brzezinski's sign, where you do this passive flexion where you kind of lift the head up, and what it does is it causes flexion of both legs, so the legs kind of start to draw up. That is also something that they'll do, and these are, if they're positive, these can be signs of meningeal inflammation or meningitis. I will tell you, NCLEX wise, I have seen questions where they ask you about these tests, so I would understand the difference between Kernig's versus Brzezinski's and how these tests are performed. So understand that Brzezinski's is passive flexion of the neck causes the legs and thighs to kind of pull up. So when you pull the neck forward, those knees and stuff draw up. And with Kernig's, you have a hard time extending that knee out without causing them pain. So just understand the difference in these two different tests that can be performed. Okay, so let's look at some of the laboratory assessments, and should say actually laboratory and diagnostic assessment pieces that go into diagnosing meningitis. So of course you're going to look at the CSF, going to do CSF analysis of that cerebrospinal fluid. Your ATI book on page 32, I believe it is, does kind of review this. So it kind of tells you, CSF should be clear. So if you see cloudy CSF, that should be an indication that there's a bacterial infection. With viral infections, however, your CSF will still be clear. So that is one thing you can kind of look at when you're doing that tap. But do also keep in mind, the amount of organisms can also play into that as well. Some other things that you'll see with bacterial meningitis in your CSF, as you can see an increased amount of white blood cells, increased protein. The glucose level will usually be decreased in that one. With viral, usually the WCs are not going to be elevated. Your protein could be normal to being elevated, and the glucose is normally normal in that particular type of meningitis. They may also do CT scans. In fact, they probably will. Your book, I wish I could remember what page it's on. They actually talk, I think it's 882, for patients older than 60 years of age, or those who are immunocompromised, who are showing signs of ICP or increased ICP. These people should have a CT scan done prior to lumbar puncture, because remember what we said about increased intracranial pressures and doing lumbar punctures. We don't want to cause herniation. So they will do a CT scan to look to see if there's increased pressures, if there's hydrocephalus or presence of an abscess actually in the brain. Blood cultures, of course, that makes sense because it's an infectious process. And then your book also mentions this counter-immunoelectrophoresis. This is used to determine the presence of viruses or protozoa in the CSF. And also, if you've already started an antibiotic before obtaining your CSF, they may use this test to take a look at it because it's a little more sensitive. We'll do a CBC and a CMP because you can have, elevations in your white blood cell count as well as shifts in your electrolytes. They may do chest x-ray, x-rays of your sinuses, and also the mastoid process to determine if there's any presence of infection there, because that could be where the original event occurred. So just some other tests that they may do. Nursing interventions for the patient with meningitis is prioritize your care. Of course, you're going to maintain your A, B's, and C's because this is neurological. They could potentially have issues with any of those things, so you want to maintain that for them. Decrease your environmental stimuli. Just like we did with our ICP patients, you're going to want them in a nice, dark, quiet room with minimal disturbances. Maintain bed rest, again, with the head of the bed elevated to 30 degrees, that 30 to 45 degree range, and this again is in case they have any increased ICP. Monitor and prevent complications such as increased ICP, so assessment of your neurological function is going to be very, very crucial to this. You're going to also, excuse me, monitor and prevent for complications such as vascular dysfunction, fluid and electrolyte imbalances. Remember, with increased ICP, they can have things like SIADH or diabetes insipidus, which could affect their electrolytes. The potential that there could be seizures associated with this, and also they could have a shock kind of situation occur with this. So older clients are at an increased risk for secondary complications such as pneumonia, so you want to be monitoring and doing good pulmonary hygiene for those particular patients. There is a chart in your book on page 882, this chart 4210, which is basically, it's from CUSIN, that the best practice for patient and safety and quality care for the patient with meningitis. It's just got a lot of good information in that particular chart, so I would take a look at that as well. So drug therapy or medications used in the treatment of meningitis. broad spectrum antibiotic, and that's the case with a lot of things we're dealing infectious agents that we can't yet identify, to start the patient on a broad spectrum. And then once those cultures and sensitivities come back, that may be adjusted based on which antibiotic is the best to take care of whatever pathogen is causing the problem. Hyperosmolar agents like mannitol, this is the one that's mentioned in your book under ICP as well. It is an osmotic diuretic. You do need to look at your serum osmolality as well as watching your electrolytes, because this is one that can cause hyponatremia and hyperkalemia, so you just kind of want to monitor those. Anticonvulsants or anti-epileptic drugs, because these patients can have seizures occur, so you want to make sure that that does not happen, so seizure precautions and stuff like that. And then steroids, this can be controversial. They may use dexamethasone. Your book doesn't actually, if I remember correctly, doesn't actually list steroids anymore. But I put it on here because you may still see those used, just so you know. Prophylaxis treatment for those in close contact with meningitis infected patients. So they may treat somebody who has been exposed. Like let's say you had an older couple that lived together, husband comes in, is diagnosed with bacterial meningitis. They may prophylactically give treatment to the wife who lived with him because there's a possibility or a chance that she was exposed and could also be infectious. So they may do that prophylactically. All right, next we're going to talk about encephalitis, which is a little bit different. Meningitis is inflammation of the meninges. Encephalitis is actually inflammation of the brain tissue itself. Oftentimes it does also include the surrounding meninges, and so you may hear a term called encephalomeningitis, or you might hear meningioencephalitis. It's kind of a mouthful, but if you think about it, either way, it's a combination of encephalitis with meninges or meningitis. And so that's just telling you that it's a combination of both brain tissue and the surrounding meninges. But with encephalitis, it's just mainly your brain tissue that we're talking about, because itis is inflammation, and so that's where we come up with this term. This one is often caused by viral agents, most commonly West Nile, we're all familiar with, but it can also be from bacteria, fungi, or parasites. In your Iggy book on page 884, there is a chart that talks about some preventative measures protecting the patient and the family from West Nile. So it just talks about stuff like limiting your time outside, between dusk and dawn, wearing protective clothing, including like long sleeve shirts, using insecticides, checking your windows and doors and stuff like that so they can't get in. And then also keeping stuff around the pools and hot tubs cleaned up, because they're attracted to water. So those are just some preventative things. With encephalitis, it's more you're trying to prevent the development of West Nile or attraction of mosquitoes or get mosquito bites. But anyway, these are some preventative things that you can do. Physical assessment wise, it's going to be very similar to all the other ones that we've been talking about. So they can have changes in their LOC, can have some dysfunction with the motor skills, if you think about depending on where the encephalitis is and what areas of the brain are being affected. So you may have some focal neurological deficits. They also will probably have sensitivity to light as well as noise. That's what that phonophobia is. Be fatigued. You'll see signs of increased intracranial pressure. So if you ever see that IICP, that's what that means, increased intracranial pressure. They can have joint pains like myalgias, things like that, headache, and may also have some vertigo issues. Again, think about that in terms of cranial nerve involvement from inflammation. That's why you're seeing that particular side effect. Okay. Also in encephalitis, which I don't really have a slide talking about diagnostics and stuff like that, because they're very similar to those of meningitis. You're probably going to get them to have a lumbar puncture to analyze the CSF and see if you can determine what organism is causing the problem. And your book mentions this polymerase chain reaction test used to detect viral DNA or RNA in the CSF, so it kind of helps you identify viral infections, as well as doing an EEG to assess brain waves. And then lastly, you may do CT scanning with and without contrast, just to look for increased intracranial pressure and to make sure there's no obstructive hydrocephalus going on, where the CSF is having difficulty draining, which can cause that pressure to rise. Because remember, we talked earlier in the lecture about that Monroe-Kelly hypothesis or Monroe-Kelly doctrine, where you have those three components, and if one of them is out of balance, the other ones have to compensate. So this is one of those things that can happen, is the CSF cannot drain properly. So you get an obstructive hydrocephalus going on. So nursing care is similar to those for meningitis. You're going to do the same things. Complications, increased intracranial pressure, kind of things that can happen. And nursing care for the increased intracranial pressure, as discussed earlier in the lecture, will be your recommendations of treatment. One thing before I start talking about some of this nutrition or dysphagia type kind of issues that can occur with these patients with head trauma and things like that, is on the previous slide on encephalitis. As I was reading it, I kind of thought I didn't put anything on here about precautions like I did with meningitis and stuff. So I did a little research, and it says that you should use enteric precautions, which basically are gown and gloves for patients suspected of encephalitis until they can be cleared. So just in case you ever see anything about what kind of PPE you're going to wear for somebody who has encephalitis, for the most part for viral encephalitis, the recommendation is gown and gloves. So just thought I'd let you know that. So on to dysphagia. I feel like this is something you guys should pretty much have a good handle on, because we talked about this with our stroke patient as well. So we're always thinking of dysphagia type diets or things that are like soft, pureed, ground up. You have to modify them a little bit. Sometimes they have to do supplemental nutrition as well as tube feedings. And I will say, in your DUDEC book, your nutrition book, on page 394, and I think 395 and a little bit onto 396, they talk a little bit about dysphagia diets. If you're not sure what that all entails, I strongly suggest you read that over. Not just for me, but I know NCLEX, there's a bigger push on nutrition and stuff like that with the different disease processes, so it's something that you may want to brush up on, not just in relation to head trauma, but if you think about all the different people that dysphagia can affect, from stroke patients to cancer patients, sometimes it's esophageal problems, all those different things. Dysphagia can become a problem for them. So understanding what constitutes a dysphagia diet would be of great benefit to you. All right, so quick review of our spinal cord injury, and I listed the EEG pages for you so you kind of look over them. Our primary focus here, is, focusing in on those things that are multi-system, like the in particular neurogenic shock. But quick little review on spinal cord injury. You have your primary injury, which if you think about this and say, just like we did head trauma, you have the primary injury, which is the one that happened at the time of the event. And then you have your secondary injury, which happens from ischemia, electrolyte shifts, and inflammatory processes. So those are the things where you're trying to intervene so that the secondary injury does not cause any more damage permanently to the spinal cord. So in your assessment piece, always airway, breathing, circulation. I think that goes with pretty much any disease process, but definitely with our head and spine issues, we want to make sure we're doing airway, breathing, circulation, because these patients can lose their airway and they can also lose their ability to innervate their diaphragm. So we may have to step in and do some breathing for them. Indications of intra-abdominal hemorrhage or hemorrhaging, bleeding around the fracture site. You're going to look at your level of consciousness, do that GCS, assess your level of injury, whether it's tetraplegia, quadriplegia, paraplegia. Is it all four extremities? Is it just the lower extremities? Is it paresis? More so it's like they have numbness or loss of sensation, but they still can move them to some extent. So there's different levels of injury that can occur. And I know when we talked in the lecture from third semester, and you may even want to look over some of those notes if you need to refresh. You know, a lot of that is determined by those dermatomes where they touch the person, and it kind of tells them at what point they can't feel, what level of injury in the spinal column that they feel like the injury has occurred. So I would just kind of go back and kind of look at that a little bit just to kind of refresh your memory. Some key assessment findings associated with your spinal cord injury. Of course, neurologically, you're going to assess the level of the injury, which we just talked about with those dermatomes. It's not just skeletal levels that are affected, but remember those neurological, like I said, testing those dermatomes and where that motor and sensory function ends. Cardiovascular system, we may see some orthostatic hypotension or even bradycardia, which puts these clients at risk for DVT. And when you think about this, think about your sympathetic and parasympathetic nervous system. You know, we have fight and flight or rest and digest. And so what can happen is that part of those pathways may be cut off. So one of them may take over, and so that's why you may see relaxation of that vascular resistance, which kind of puts them at risk for this orthostatic hypotension because they can't maintain that constriction on their vessels. So that's why they kind of get this way. Or the parasympathetic system may take over, and that's why we kind of wind up with this lower heart rate because we can't innervate through the sympathetic nervous system. So that's just some of those things that kind of happen with this. Respiratory system may be compromised. It depends on the level of the injury. Remember that C4 and above is kind of your area. If you see anything above that level of injury, you do have to worry, can the patient maintain their own respiratory drive? Can they innervate that diaphragm to be able to do the work of breathing? These people may wind up permanently with mechanical ventilation in order to breathe. And then GI-wise, they are at a high risk for paralytic ileus. Again, you have to have innervation going to the bowel to move things along or to keep that peristalsis going. And so it's not uncommon for them to develop this shortly after an injury. It's not that it becomes permanent, but it's just like it just kind of gets shocked into not working for a little while. So that is something that we do have to watch for as a paralytic ileus in our patients. Now, some of the primary focus of what this is, you know, this lecture in particular, I want to do a quick review of the spinal cord injury stuff just so we could talk more about neurogenic shock. It's most commonly seen in clients with injuries above the T6 or that thoracic 6 level. You know, that's kind of the golden number 2 for autonomic dysreflexia. So anybody with a T6 or higher is prone to the development of neurogenic shock. It may occur within 24 hours of the injury, and what you have is a loss of the sympathetic control below the injury, which allows that parasympathetic output to go unchecked. And so when you think about your autonomic nervous system, that sympathetic and parasympathetic, you know, the sympathetic is that fight or flight. It's the one that kicks in, gets us ready to fight or ready to take off. And the parasympathetic is just opposite that. That's the rest and digest system. So when the sympathetic is not there, the one that kind of slows everything down takes over, and that's why we see decreased vascular resistance and dilation of the vasculature, and that's why we have blood that pools in your lower extremities, which leads to that hypotension that we see associated with this. So usually the treatment for that is to give them fluids and some vasopressor medications as needed. I did list on here, and these are listed again at the end of the presentation, the different videos. There's 2 different videos if you're having a hard time understanding this concept. The neurogenic shock one goes over a little bit of treatment too from Khan Academy, and Nurse Sarah does a great job on her registered nurse RN videos going over this particular concept. So I highly suggest you watch at least one of those because it will definitely help you with. So what are some of our manifestations, or what do we see as signs and symptoms of neurogenic shock? Well, first is hypotension, like you see with most of the shocks. And this is occurring because of that vasodilation, which decreases your venous return. You know, your blood flow has to have resistance to keep it moving forward. So if it loses that resistance on the outside, and that it's not a narrow, it's more of an open, like floppy on the outside, that vascular resistance is going to be down. So this causes hypotension. And when that happens, our mean arterial pressures fall. And when our mean arterial pressures fall, what does that mean? Well, it means that our main organs are not going to be able to get perfused because we're not maintaining that mean arterial pressure. This particular type of shock is the only form of shock that you will see bradycardia with, and it goes back again to the fact that that parasympathetic system is left unchecked because the signals can't be sent from the sympathetic nervous system. Normally, when you think of shock and hypotension associated with that, whether it be from hypovolemia, sepsis, whichever type of shock you're talking about, the normal response when our blood pressure drops is the heart rate takes over and tries to pick up to compensate for that. But we've lost that compensatory mechanism with neurogenic shock because those pathways, that sympathetic system can't respond the way it needs to, and so we wind up with bradycardia with this patient as well. And because of those things, we have decreased cardiac output, because what is our cardiac output? Consists of our stroke volume, right, and our heart rate. Well, we know our heart rate's low because we're bradycardic. Our stroke volume is not going to be great because we have no vascular resistance to push the blood forward to get it in there. So our cardiac output is going to fall dramatically with this type of shock, which leads to organ dysfunction. So you can look at those first four things and manifestations and know already if this is occurring, your patient is in trouble unless you stop and intervene. Another thing that happens is they lose the ability to regulate their temperature, so they become hypothermic. And the weird thing about this is because the blood pools, because of that decreased resistance, and so you have that vasodilation, you have all that blood kind of pooled, the skin itself actually feels warm and flushed. So you would think they would be hyperthermic by looking at them and touching them, but internally their temperature is actually cool. So it's kind of, like I said, this is kind of a weird type of shock. It's kind of fascinating in a way, but that's something that happens. And because you have that loss of vascular resistance and everything's pooling, you can wind up with some dependent edema. So those are the clinical manifestations you will see with neurogenic shock. So now that we've recognized, hey, I got a spinal cord injury patient who had a level of injury above thoracic 6 or that T6, who I'm now seeing hypotension, warm flush skin, bradycardic with edema, and if I'm doing an internal temperature reading, I'm grading them as being low. Now I've recognized, hey, I've got, I think, neurogenic shock going on. What do I need to do as the nurse to fix this problem? Well, there are a couple various things that you can do. Administer fluids, because you need to expand that volume, because remember, all those vessels are open and dilated, so you've got to refill that back up to get that pressure moving forward. You're going to utilize vasopressor agents. A lot of times it's dopamine is kind of the drug of choice. I will say your book on page 898 under the intervention section will tell you a little bit more about what they do here. It's just like a paragraph long. It doesn't take but probably 2 minutes to read, if at that much. And then lastly, because the heart rate cannot respond because of bradycardia, you may have to give atropine if the bradycardia becomes severe. So if it's like 60 to 50, that's considered severe enough that they would probably go ahead, especially if it drops below 50, that they're going to go ahead and give the patient atropine. Your book also talks about giving dextran, which is a plasma expander, again, to get volume into the vessels so we can increase blood pressure. So if we can increase that blood pressure, we can push the blood through. So if we push the blood through, we have increased our stroke volume. Now I'm giving atropine, which is going to increase my heart rate. So if I can increase my stroke volume and my heart rate, I'm going to increase my cardiac output. If I increase my cardiac output, now I'm perfusing my organs again. So I'm fixing all those problems, those first four things on the previous slide that told me, oh boy, my patient's in trouble. I better do something or I'm going to wind up in a multi-organ system failure problem. So these are your interventions for neurogenic shock. Okay, so now we're going to talk about spinal shock, or something called spinal shock syndrome. And this is found in your ebook on page 896, as well as in ATI. There's a short little paragraph on page 98 in your ATI MedSurg book. This is basically just an immediate response to the cords injury, and it's due to inflammation that's caused by the injury, which makes sense. Like I always say, if you punch somebody, you're probably going to have an inflammatory response. And so this is what's kind of happening here. So the patient will have a complete loss of motor, sensory, reflex, and autonomic function. Now keep in remember what your autonomic nervous system does, because I just talked about that in a neurogenic shock. However, even though you can see some autonomic dysfunction problems, there is a difference between neurogenic shock versus spinal shock. And I know it's a very fine line, but they are not the same thing, even though sometimes the treatments may be similar. This can last up to 48 hours, but may continue for several weeks. Reflexes return to specific pattern, typically, with the cutaneous reflexes generally returning before your deep tendon reflexes return. So like I said, this is just a brief little overview of spinal shock. What kind of manifestations will you see with this particular disease process or syndrome? Well, muscle weakness, loss of voluntary muscle movement in the chest, arms, or legs. So because of that, you can see the potential for breathing problems. Loss of feeling in the chest, arms, and legs. Loss of feeling, and movement. Loss of bowel and bladder function. Remember I talked about paralytic ileus. This is one of those things that can happen as well with spinal shock because of that inflammatory process. It affects the innervation, which can lead to that. And then also you can have that hypotension and bradycardia if you start involving that autonomic nervous system again. So this can also happen from spinal shock, but this is caused from that inflammatory process itself. So how do we treat it, or what do we do with this particular disease process? Well, usually you treat the symptoms, so it's symptomatic treatment. So fluid resuscitation, oftentimes with something that's isotonic like LR or normal saline to help with the hypotension, just kind of like we did with neurogenic. Yes, you may have to give vasopressors if you have a decrease in blood flow due to hypotension to the spinal cord or to the organs. Depending on what you read, and our books no longer, which I'm kind of glad, our books no longer talk about high-dose steroids. It used to be when somebody had a spinal cord injury, we used to give them like massive amounts of high-dose steroids. Because the thought is if you decrease the inflammation, then it makes it better. But that reasoning never really held true. We didn't see the benefit that we wanted, and giving something high-dose steroids can cause a whole litany of other problems. So that's something that's kind of gone away from the literature, but I included it in here because you may still see this in certain settings. So just in case, just so you know that sometimes you will still see high-dose steroids given to patients in spinal shock to decrease inflammation. You do want to try to keep their mean arterial pressure at least at 85 millimeters of mercury to prevent any further damage to the spinal cord or to any of the other organs. So you want to kind of maintain that blood pressure a little higher. So signs and symptoms, they will spontaneously resolve on their own. And so you'll see some spasticity occur. And if you've ever seen muscle kind of wake up, that's usually what happens. They'll start having reflex bladder emptying, so they'll be able to do that, as well as they'll start having some hyperreflexia with increased muscle tone. And once the spinal shock resolves, then you can begin rehab with this patient. This is why a lot of times after spinal cord injury, immediately after, we don't really know what function the patient will actually have because we've got this spinal shock and this inflammation and this inflammatory process going on. We need to kind of let everything kind of tone itself down and kind of calm down before we can actually ascertain what kind of function will be left for the patient. Okay, I can't do a lecture without some kind of homage to YouTube videos. And of course, I've got Khan Academy on here. It's always been one of my favorites. So I've got on here, what is shock, differentiating shock, neurogenic shock, which that actually is a really good video. The other ones just help you with the general concepts of shock, so those are good things to review. And then they also have one on bacterial meningitis from Khan Academy that you can find on YouTube. And then the registered nurse RN, or Nurse Sarah, she has two really, really good videos on. One on increased intracranial pressure, which that one's about 32 minutes long, so it's a little bit longer, but she has a tremendous amount of really great information in there. She's got some good mnemonics to help you guys remember some things to prepare for your test. She's also got a really nice video on neurogenic shock as well. And then since we were talking about neurogenic shock and spinal shock, I did find another video, and this I just put as other, and this one's done by the ACL Certification Association, that compares neurogenic shock versus spinal shock. It is only about like 4 or 5 minutes. It's a really quick little video on those concepts that can be really beneficial. I will tell you that the neurogenic shock and that increased intracranial pressure from Nurse Sarah, if you're going to spend some time watching videos, those are probably the two that I would, if you only have a little bit of time, those would be the ones I would definitely tell you to watch, as well as the bacterial meningitis one from the Khan Academy. But they just do such a good job with the pictures, explaining what's going on from a patho standpoint, that can also help you understand your nursing interventions a little more thoroughly.